Hi, and thanks for tuning in to this presentation on motor neuron disease and neuropathies. Today we'll explore various aspects of electrophysiological testing, nerve conduction studies, and clinical electromyographs in the context of the conditions. This presentation is brought to you by Group 1, featuring Hannah Billings, Brent Camacho, Kelsey Davis, Brittany Findle, Jackson Hoggett, Jill McGuffey, Hannah Waller, and Chrisanna Weaver. Alright, so let's get started with the objectives of this presentation. Our goals today are to understand the purpose of electrophysiologic testing, identify key principles of nerve conduction studies, recognize the differences between motor and sensory nerve testing, understand the clinical relevance of light waves, recognize the role of clinical electromyography, and finally identify abnormal EMG findings and their significance. So by the end of this presentation, you should have a comprehensive understanding of these core topics. So for instance, if you've ever experienced tingling or numbness in your fingers after prolonged use of your phones, you might have wondered if it was a nerve issue. So electrophysiologic testing can help pinpoint whether or not it's a temporary irritation or something more serious, for instance, like carpal tunnel syndrome. Okay, so let's jump right into electrophysiological testing. Electrophysiological testing, often referred to as electrodiagnostic testing, is used to evaluate the function of the nervous system. While it primarily focuses on nerves in the periphery, it can also provide some insight into the central nervous system function. The purpose of these tests is to assess the damage of the myelin or axons in nerves, diagnose the severity and type of nerve damage, whether it's axonal or myelin, and determine whether it's chronic or acute. Okay, so let's break it down. Think of it as a way to listen into your nerves to see how they're communicating with your muscles. Imagine you're trying to talk on the phone. There's static, and then the call drops entirely. That's what happens when the nerves are damaged. These tests can assess whether the issue is with the phone line itself, axon damage, or the insulation around it, myelin damage, helping diagnose conditions like carpal tunnel syndrome or diabetic neuropathy. As I stated before, electrophysiological testing evaluates the function of the nervous system. So imagine you're troubleshooting a malfunctioning appliance in your home. You check whether or not the problem is with the appliance itself or with the wiring. Similarly, electrophysiological testing checks whether the patient's symptoms are due to issues in the nerves or the muscles. So for example, in conditions like multiple sclerosis, the myelin is damaged, which is going to lead to slower nerve conduction. Okay, so let's talk about nerve conduction studies. So the purpose of a nerve conduction study is to measure the electrical response of peripheral nerves to evaluate their health and integrity. The process involves depolarizing a large number of axons with an electrical stimulator. If the nerve innervates a muscle, the response is recorded as an EMG. Key findings for a normal conduction indicate healthy nerve function. Partial damage will show slower and smaller responses, and complete damage will result in no response. So, as I stated, nerve conduction studies are used to measure the electrical responses of the nerves. So if you've gone to a doctor's visit and you had your reflexes checked, that's a very basic form of nerve testing. In nerve conduction studies, we take this step a bit further by applying a small electrical stimulus to the nerve and measuring the response. A healthy nerve will respond quickly and strong, just like a well-maintained road allows traffic to flow smooth. If there's damage, such as in Guillain-Barré syndrome, the response might be slower or weaker, indicating a traffic jam or roadblock, for instance. So they're also going to measure how well electrical signals travel along your nerves. Think of it like testing the speed and quality of your Wi-Fi. If there's good connection, you get fast and reliable internet. If there's interference or damage, the signal will weaken or drop entirely. In nerve conduction studies, we apply small amounts of electrical stimulus to the nerve and measure the response. A healthy nerve will transmit good signal, quick and strong. However, in conditions like carpal tunnel syndrome, the median nerve is compressed, causing a slower or weaker response, just like bad Wi-Fi connection. Okay, let's talk about the differences between motor versus sensory nerve testing. Motor nerve testing is used to evaluate the function of motor nerves, which are going to control muscle movements. Sensory nerve testing is going to be evaluating the function of the sensory nerves, which are going to transmit information like touch, pain, and temperature to the brain. A complete nerve conduction study includes testing at least 2 sensory and 2 motor nerves in an affected limb. Ideally, similar tests should be performed on the contralateral side and another limb for comparison. This helps differentiate between nerve and muscle disorders, localize the site of nerve damage, and monitor disease progression in response to treatment. So imagine you're typing on a keyboard. Your motor nerve controls the movement of your fingers, while your sensory nerves let you feel the keys. If you have a problem with motor nerves, you might find it difficult to press keys down properly. If it's a sensory nerve issue, you might not feel the keys under your finger, even though you can still type. Testing both of the nerves helps identify whether the issue is more likely to be a muscle problem or a nerve problem, and it localizes the exact site of the nerve damage. Nerve conduction studies measure 2 key parameters: latency and amplitude. Latency is the time between the stimulus and the response at the recording site, while amplitude reflects the strength of the nerve's response. Prolonged latency or reduced conduction velocities can indicate damage to the myelin. When electrical stimulation is applied to a nerve, there's a series of events needed to initiate an action potential. That's going to include charging the tissue compliance and opening voltage-gated ion channels, which is termed utilization time. So we know that latency and amplitude are 2 key measurements in nerve conduction studies. So think of latency as the time it takes for a message to get from your brain to your muscles, kind of like sending a text message. Normally, the text should arrive almost instantly. If there's damage, like multiple sclerosis, it might take longer, which is going to show prolonged latency. Or if the text doesn't go through at all, it might be signs of reduced amplitude. Conduction velocity, on the other hand, tells us how fast the text is traveling. If you've ever tried to send a message over poor Wi-Fi, then you know that it's going to be frustratingly slow. That's similar to what happens when the nerve's myelin is damaged. Next, we're going to be talking about F waves and H reflexes. So F waves and H reflexes are important late muscle responses that provide diagnostic information. F waves occur when a stimulus travels up the spinal cord and back down, testing the entire length of the nerve. H reflexes, or Hoffman reflexes, use the monosynaptic stretch reflex circuit and can help diagnose musculoskeletal conditions and neurological function. Both are essential for assessing proximal nerve function, including brachial and lumbosacral plexus. F waves and H reflexes are kind of like an echo response of the nerves. So imagine you're in a canyon and you shout. If the canyon is clear, your voice echoes back clearly, like healthy nerve responses. F waves and H reflexes work similarly by sending signals up and down the spinal cord to test the nerve's function. F waves can help diagnose conditions like demyelinating diseases, where the echo might be delayed or absent, similar to what you would experience if the canyon walls were covered with a thick foam, dulling the sound.
In a clinical electromyography, or we can also call it an EMG, a small needle is inserted into the muscle to record the electrical activity of a single motor unit. So the shape, duration, and amplitude of the waveform can indicate whether the muscle and the nerve function are normal or if there is a pathology. So an abnormal waveform, such as those that are too brief, long, small, large, or complex, can be signs of specific conditions. So if we can imagine that the muscle acts as an orchestra and the needle is a microphone, so in a healthy muscle, all the instruments, which will be our muscle fibers, play in harmony, creating consistent and clear sound. So that's going to be your waveform. So if there's a disorder such as an ALS, some instruments might play out of tune or just stop altogether, which will lead to a distorted or even a chaotic sound pattern. So these abnormalities can help us pinpoint the exact nature of the issue. So now we'll talk about spontaneous potentials and abnormal EMG findings. So when the muscle fibers of a motor unit are initially separated from the motor neuron, they will start to atrophy and generate spontaneous action potentials in an individual motor unit fibers called spontaneous potentials. There are three different types of spontaneous potentials, or positive sharp waves, fibrillation potentials, and fasciculations. So clinically, positive sharp waves and fibrillation potentials mean the same thing and are highly specific signs of an axonal injury. So we can look at it as a positive sharp wave and a fibrillations are like kind of like a warning sign or a warning beep that indicates a muscle fiber is no longer receiving a proper signal from its nerve. So fasciculations are not always a sign of neuromuscular pathology. Sometimes the fasciculations can be associated with fatigue and thyroid disorders, but they can also result from peripheral or lower motor neuron injuries. So, for example, when a person is tired and their eye twitches involuntarily, this fasciculation doesn't cause concern. However, when they are widespread and cannot be explained by other circumstances, then becomes concerning. So, by understanding these findings, it can helps us pinpoint the type and the extent of the nerve damage. Now, let's look at diagnosing radiculopathy with EMG. So EMG plays a crucial role in determining whether muscle weakness or numbness is due to a problem in the muscle itself or the nerve supplying it. So let's look at this for an example. If a patient is experiencing foot drop, it could be due to a muscle problem like in muscular dystrophy or a nerve issue such as a pinched nerve in the lower back. So when we combine EMG with NCS, this will help us distinguish between these possibilities. So to diagnose radiculopathy, we need to observe spontaneous potentials like fibrillation potentials and positive sharp waves in specific muscles. So the test must include one paraspinal muscle and two peripheral muscles innervated by the same nerve root to be definitive. So a negative EMG, however, does not completely rule out radiculopathy. Now, if there is severe radiculopathy that occurs, then Wallerian degeneration may occur, and this will show fibrillation potentials and positive sharp waves on an EMG due to muscle fibers spontaneously firing. This also has a characteristic visual appearance and a distinct auditory sound as well. So now we'll look at the steps for selecting appropriate nerves and muscle tests when planning an electrical physiological test. So we want to make sure we review the suspected pathology based on the clinical suspicion. So for example, carpal tunnel syndrome or radiculopathy. We also want to consult CPGs as well as determine sensory and motor tests. So we can do this by using NCS for motor and sensory nerves and select appropriate muscles for EMG based on suspected nerve root involvement. Now, one thing that we need to know, it's crucial to test both the affected and unaffected limbs. So imagine that you're comparing two identical cars to see why one isn't running well. By testing both, you can identify the issue more clearly. So, for example, let's look at a patient with carpal tunnel syndrome. If we test both hands, it can show us whether the problem is limited to one wrist or if it's a systemic issue affecting both wrists. Another example we can look at is if we think of comparing like a damaged copy of a book to the original book. So by reading both, we can figure out exactly where the missing pages are and what information is lost, which helps us guide in our diagnosis and treatment plan. Now we'll look at a summary of everything we've discussed so far. So, electrodiagnostic testing. It's essential for diagnosing and managing neuromuscular disorders. It also helps us distinguish between muscular and nervous system disorders by providing us prognosis for conditions like radiculopathies and guides treatment planning. So by understanding this integration of NCS and EMG results, it's critical for identifying the lesion's location and disorder's nature, whether acute, subacute, or chronic. So let's look at this for an example. If a patient has an unexplained muscle weakness, NCS and EMG can reveal whether the issue is due to nerve damage, such as in Guillain-Barré syndrome, or muscle damage, such as in muscular dystrophy. All right, so now what we'll do is we'll review some MPTE practice questions just to test your understanding and to see if the information we provided was helpful. Which of the following best describes the difference between an F wave and an H reflex? A. F waves are considered late waves while H reflexes are not. B. H reflexes involve gamma motor neurons and muscle spindle organs, but F waves don't. C. H reflexes use the monosynaptic stretch reflex to travel and cause an action potential, but F waves don't. And D. F waves occur when the action potential travels to the spinal cord and back out, but H reflexes don't. So just take a second, you can pause the video, and we'll go over to the next answer. Alright, so the correct answer was C. H reflexes use a monosynaptic stretch reflex to travel and cause an action potential, but F waves don't. So H reflexes occur when the peripheral nerve is stimulated, activating the 1A afferent fibers for the action potentials to travel into the spinal cord. So once in the spinal cord, the action potential is monosynaptically attached to the alpha motor neurons, creating an action potential. So F waves do occur when the peripheral nerves are stimulated. However, they do not activate the 1A afferent fibers. Only the alpha motor neurons are activated. Is it important for complete nerve conduction studies to include both sensory and motor nerve studies? A. No, sensory nerve tests are more sensitive than motor, so you would only do sensory. B. Yes, if a nerve only has mild damage, then the motor test may appear normal while the sensory test will display the damage. C. Yes, motor nerve tests are more susceptible to technical error, so doing the sensory nerve test with it reduces the risk of error. D. No, motor nerve tests are easy and will provide similar results to the sensory nerve test. Let's take a second, pause, and we'll get to the answer. So the correct answer is B. Yes, if a nerve only has mild damage, the motor test may appear normal while the sensory test will display the damage. So sensory nerve tests are more sensitive compared to motor nerve tests. When the motor nerve tests are performed, it's easy to elicit a motor response even with mild nerve damage because there's a significant amount of current being used. Sensory tests don't produce an observable reaction, so we can use the conduction of velocity to detect damage because it will show a recognizable decrease. The following is not considered a spontaneous action potential: A. Fibrillation potential. B. Positive short wave. C. Fasciculation. D. Satellite potential. Just take a second and pause, and we'll get to the answer. The correct answer is D. Satellite potential. Satellite potentials are secondary to spontaneous action potentials and result from compensatory mechanisms and partially denervated muscles. They are like backup signals trying to restore communication rather than direct spontaneous signals from the nerve or muscle damage.
Nerve conduction studies are used to assess the health and integrity of peripheral nerves by measuring their electrical responses. Which of the following conditions would a nerve conduction study be most useful for diagnosing? A. Stroke. B. Myasthenia gravis. C. Carpal tunnel syndrome. Or D. Multiple sclerosis. The correct answer is going to be C. Carpal tunnel syndrome. So carpal tunnel syndrome is a condition involving the compression of a peripheral nerve, in particular the median nerve. So it's going to make a nerve conduction study an appropriate diagnostic tool. A 45-year-old patient presents with complaints of muscle weakness and numbness in their left lower extremity. The physical therapist orders an electromyograph and a nerve conduction study to differentiate whether the issue is due to a muscle disorder or a nerve disorder. During the EMG, fibrillation potentials are observed in the left quadricep. Which of the following best describes the likely cause of the patient's symptoms? A. Muscle atrophy. B. Peripheral nerve injury affecting the common fibular nerve. C. Radiculopathy involving the L3 nerve root. Or D. Muscular dystrophy. So the correct answer is going to be radiculopathy involving the L3 nerve root. The presence of fibrillation potentials on the EMG is going to indicate an abnormal electrical activity in the muscle, and that's commonly associated with denervation, such as a nerve root injury.
Alright, so that concludes the presentation. We just want to say thank you for watching and listening to this. We hope you now have a deeper understanding of motor neuron diseases, neuropathies, and the role of electrical physiological testing.